patients, when they have a biopsy on their nose for a skin cancer, are less stressed out than if you go to biopsy their scalp.
What's the likelihood, doc, I'm going to lose all my hair or I'm going to lose every hair on my body?
Well, we know that over 50% of patients, and once we treat them and we're able to regrow their hair, they are smiling, they want to hug you, they are so happy, and it really makes your job as a dermatologist so much more rewarding. As a general rule of thumb, if you stop the treatment, you will likely lose the progress that you've made. Now,
welcome to Derm-It, Trotter. Don't swear about skincare, where host Dr. Shannon C. Trotter, a board-certified dermatologist, sits down with fellow dermatologists and skincare experts to separate fact from fiction and simplify skincare. Let's get started.
Welcome to the Derm-It Trotter Don't Swear About Skincare podcast. We are excited to be here today to talk more about inflammatory disease, but hair loss, guys, the things we're all worried about. I've got Dr. Eric Dominguez here on the show today. He's a board-certified derm, owner of Modern Dermatology. He's an assistant clinical professor at the University of Massachusetts Chan Medical School, and he loves anything with inflammation in the skin, so hair loss is his jam. Welcome to the podcast, Eric. It's great to have you here.
thanks so much, Shan. I'm so happy to be here and to discuss alopecia areata in particular.
Well, one thing I'm going to have you break down is just that term you use, alopecia. I don't know how many times I have people come and say, oh, do I have alopecia? And I think they only understand like how broad of a term that really is, right? That refers to multiple types of hair loss. But you and I are going to talk about a very specific subtype of that, alopecia areata today, that we know is autoimmune in nature. I'm going to have you explain that a little bit for our audience because they may be more curious about it. But I think what got interest and attention, I love to mention this, that slap heard around the world at the Oscars. Jada Pinkett Smith, Will Smith, that was really a popular instance, when that happened and really drew attention to the word alopecia, but more specifically, she was talking about alopecia areata. So I want you to break it down for me. What is alopecia areata?
So alopecia areata is actually a very common autoimmune skin condition where essentially your body's inflammation cells decide to attack the hair follicles. And when they attack the hair follicles, the hair falls out. It's one of those types of hair loss that you can go to bed one night with a full head of hair and wake up the next morning missing all of your hair potentially, or just patches of hair loss. And it can be quite detrimental to someone's emotional health. And yes, it's one of those conditions that patients certainly are quite concerned about. And I like the point that you bring up about alopecia. What is alopecia? So alopecia just means hair loss, right? There are several different types, as you alluded to. A very common one certainly is alopecia areata. We have the female and male pattern hair loss, other types of alopecia as well, where you lose your hair. But of course, alopecia areata is certainly one of the most common ones that we see in many different ages, a lot of times even presenting in children, young adults, adolescents, teenagers, but certainly can occur at any age.
So we talked about, it's autoimmune, our own immune cells, those T cells or T lymphocytes we talk about are attacking, the hair follicle and then essentially cause, that hair to fall out. How does it tend to present? Because I think a lot of people are wondering, well, I feel like I have shedding. I feel like I'm losing hair. Do I have alopecia areata?
Well, most common way to present with alopecia areata are these coin-shaped patches of hair loss, very commonly on the scalp, but can also impact the beard, eyebrows, eyelashes, arms, legs, or other areas on the body, but certainly the scalp, the eyebrows, and the eyelashes can be the areas that certainly cause the most emotional distress because they're areas that patients can't hide. And of course, that's when it's more localized. You can certainly present a little differently where there's really some diffuse thinning of your hair. And that can be a little bit difficult to distinguish between male or female pattern thinning versus diffuse alopecia areata. And certainly you can also have just involvement of the eyebrows, just involvement of the eyelashes, or you can have a combination of all of these. A more difficult type to treat and to actually have is what we call the ophiasis pattern, where essentially you have hair loss that goes from the back of your scalp from ear to ear, back here essentially. And it can be quite difficult to treat, but certainly if someone sees a physician who treats patients with hair loss, with alopecia more specifically, you may certainly be able to have this diagnosed.
And have you ever seen patients too that could have it just a particular, like just the eyebrows or just the eyelashes or just the beard, and maybe it's not hitting the scalp where most people think of it as occurring first?
Absolutely. You certainly can see that. I have patients in my clinic who present with just loss of their eyebrows, just loss of the eyelashes. And that at times can even be more detrimental than their scalp. As you can think, for a scalp, you could put a hat on, a wig potentially, but your eyebrows and eyelashes, you can't really hide that as well. And that can be very emotionally distressful for our patients.
I can speak from personal experience, not from alopecia areata, but from overplucking in the 90s and lost most of my eyebrows. So I even get my microbladed because without those eyebrows, I mean, your face, it just frames your face, right? People can feel very different, and it's very hard to do something that looks authentic to replace that hair. Where I've had patients say the same thing. They're like, I can get something to put on my scalp, a hair prosthesis or a wig, and I feel like I can fix it, but eyebrows or eyelashes, man, that's tough. And you're right, that has an emotional toll. I mean, we definitely think of women, but it does affect men similarly, where it can take that emotional toll as well. So if somebody is wondering about alopecia areata, like, and they think they might have it, how would you diagnose it? 'Cause I think that's probably one of the things people are thinking. Again, I have hair thinning. Wait, it looks kind of patchy. It's kind of diffuse. I mean, my eyebrows have started to go away. Do I have it? How would you actually diagnose it in office?
The number one way to really diagnose alopecia areata is clinically. Basically, how does it look? Does it present similar to alopecia areata? Is it missing other findings that you may see in other types of hair loss? Certainly, if you have eyebrow, eyelash involvement, and patchy scalp loss, that certainly
Hmm.
can indicate alopecia areata. But if you have just diffuse hair thinning, certainly, as we discussed earlier, that could be indicative of a male or female pattern thinning or diffuse alopecia areata. If you see other signs, redness, scaling, it could certainly be another type of hair loss as well. We know that certain types of inflammation in the scalp, whether it could be severe psoriasis, can cause some hair loss, severe seborrhea, which is essentially a type of severe dandruff, can also cause some thinning of the hair. So really having that clinical presentation can be certainly very helpful. But when in doubt, a scalp biopsy can also be performed, and that certainly can also lead to a correct diagnosis if the diagnosis is in question and not completely conclusive for alopecia areata.
In a scalp biopsy, do you feel like it's a pretty intimidating thing to have done, or pretty simple practice that you can use to, help really define what's going on?
I would say, as a clinician, dermatologist, I find scalp biopsies to be fairly simple because when I was
Mhm.
a resident, we did a lot of these. However, as a patient, I can imagine it's actually very stressful. I will tell you the truth. Patients, when they have a biopsy on their nose for a skin cancer, are less stressed out than if you go to biopsy their scalp. We know the scalp is certainly one of those areas that bleeds quite a bit. And for a novice clinician, that might be something very difficult to consider because all that bleeding that can certainly happen. What I've learned is if I have a patient doing a scalp biopsy, I have you come in 30 minutes early. We're going to numb up that area, let the numbing sit there as long as we can. And actually, by doing so, also those patients will bleed less. That's really my tidbit of advice that I give to newer clinicians out there is let the numbing sit there, lidocaine with epinephrine, let it sit there for 30 minutes. It also gives the patient comfort knowing that the numbing has really kicked in and is certainly not going to be a painful process for the patient.
Yeah, and I like how you highlight, clinically we often can make the diagnosis, but there are times where it's trickier, like that diffuse variant that you mentioned, or alopecia areata incognita, where it can be a little bit more difficult, to figure out what's going on. And then, strikingly enough, in some folks, there might even be an overlap of hair loss that's going on, especially in patients that might be older that do have that male or female thinning, or even early on. Some patients will experience that too. So I think biopsies can be helpful to clarify that picture, but you're right, it can be a little scary if you're the one going through it. And also on the clinician side, if you're not experienced performing the procedure as well. And I think for those that are sitting there wondering, okay, if I have alopecia or I know somebody who's got it, is there something that we can think of that maybe triggered it? I think that's always, a common question in the office, right? What
Right.
did I do that caused this? Was it something I ate? Was it something I took, like a medication? Is it family history? What actually contributes to the fact that they've even got alopecia areata in the first place?
That's a great question. I think one thing that patients always like to find out is there something that I did or that I'm doing that's causing this? I think we're very quick to blame ourselves for this happening when it does happen to ourselves. But we know that, there are several things that have been known to potentially trigger this, whether it be stress, whether it be illness. We know certain vaccines have done it, maybe some medications, but a lot of this also has a genetic predisposition. Many of our patients who have alopecia areata have a parent or a sibling who have also had a similar condition in the past. I myself in college had an episode of alopecia areata in my beard. It happened
Wow.
without a family history. And,
Hmm.
college as a chemistry major, very stressful, a lot of long nights of studying, not sleeping enough. And that type of stress on the body certainly could have triggered it. And it's happened maybe once or twice since then, but really not something that persisted. But we know that for other patients, certainly it can persist. But certainly stress will potentially trigger this for some patients, along with that genetic susceptibility.
And I think everyone knows stress all too well these days, right? I feel like everyone's feeling it, whether it's us, a day-to-day work and battling insurance companies and trying to get medications for our patients and keep up with day-to-day activities, and our patients coming in, work, life. I mean, stress just, I think, has infiltrated so many aspects of, where we're at, and it can be challenging. And, I think people sort of brush it off, right? Oh, it's just stress, and don't realize it can have a toll on the body. And you're right, that link to autoimmune disease like alopecia areata can happen. I always like to remind patients too, we see this, we talked about that genetic predisposition that can run in families, that, there are a lot of families that just have what we call that kind of autoimmune look to them, or what we call phenotype, where you look in the family and somebody's got, thyroid problems, and somebody else has lupus, and somebody has psoriasis, and they just happen to have alopecia areata. And like, why is that? And then I just tell them, you know what? Genetically, your immune system is really primed to just be hyperactive, and how it then presents in these different conditions, probably a mix of things we don't totally understand, but also the uniqueness of your own immune system. And so autoimmune disease does like to ride in families. So that genetic predisposition, as you mentioned, totally a real thing that we have to educate patients on as well. And I think too, when they wind up getting alopecia areata, which can be obviously distressing, and especially if they're presenting that patch form that you mentioned, I wanted to circle back to that, because you mentioned like how, you could have the patch form where it's these discrete, like very well-defined areas that might look like, dime size or quarter size on the scalp, or it can be diffuse patchy where it's a little bit more ill-defined and a little bit broader with those patches, or maybe it's diffuse overall where it mimics, male or female thinning. And then of course you have those patients where it's involved their entire scalp. And then those folks that go on to have involvement with their entire body hair. I wanted you to talk about those two different types of alopecia areata. And then also, if you start off with just a little, what's that likelihood of progression? Because I think that's what a lot of people are fearful of, right? Like, this is what I've got, but what's the likelihood, doc, I'm going to lose all my hair, or I'm going to lose every hair on my body?
Well, we know that over 50% of patients do develop additional patches within the first 6 months. So if you have alopecia areata, you really want to get that addressed as soon as possible. We also know that if someone has at least 50% scalp involvement, there's a less than 10% chance of spontaneous remission. Therefore, if your scalp is getting worse, if you're getting more patches, you need to have this addressed immediately. I almost call it like a medical emergency. You have this risk of certainly losing all of your scalp hair, potentially losing all of your body hair. When you lose all of your scalp hair, it's called alopecia totalis. When you lose all of the hair on your body, it's alopecia universalis. Interestingly, when I have seen that in some patients, females in particular will complain and say, Doc, I've lost all my hair except for my armpits. I still have to shave my armpits.
They
Right.
love
So,
that. I would
right.
love
You're dealing with losing the hair,
that.
and certainly you still have to deal with shaving in an area that is very inconvenient. Now, luckily now things have changed where we certainly have treatments to discuss, but this is years ago when we didn't really have any, consistently effective treatments. We also know that about 1/3 of patients have disease lasting more than a year. And I'll see this. I have patients who will treat them. They do better, they wax and wane. You treat, they come back 6 months later, Doc, I have a new spot that popped up. And these patients know to call us right away. And in my clinic, we know if someone is having a flare-up of their alopecia areata, we consider that a quote unquote emergency. Let's get that patient in within a week to really address what's going on. Because again, we know that they can progress to lose all of their scalp hair and potentially even lose all of their body hair as well.
Yeah, and it's got to be such a scary thought. You're already dealing with the stress of what you have, which can add to the hair loss even further, obviously. And to know that progression is a real thing, I think linking that to treatment, something we'll touch on in just a moment. But going back to kind of, thinking about alopecia areata a little bit more on a complex level, from the standpoint that, okay, we know it involves obviously the hair follicle, but what other conditions? Because people probably wonder, if I have alopecia areata, am I at risk, or potentially are there other conditions associated with it that I need to be on the lookout for, or that I'm more likely to develop? How do you educate your patients on what they could be potentially at risk for, or what's associated with alopecia areata?
I like to let patients know that alopecia areata itself does not cause other conditions. However, the cells that are attacking your hair follicles are attacking other parts of your body. We know that thyroid disease is certainly one of the most common that we see in patients. I also have patients who have other skin conditions as well. Vitiligo is a common chronic autoimmune skin condition. Psoriasis, eczema. We can also see lupus, pernicious anemia. So really any of these types of autoimmune conditions certainly can also be impacted and result along with alopecia areata. What I do is I basically just get a good history. And a lot of times these patients already have a diagnosis of thyroid disease or type 1 diabetes or pernicious anemia or lupus, etc. But certainly getting a good history and then also discussing with the primary care team, these are things I'm worried about. When you check regular labs, please also consider checking these labs as well, because sometimes patients don't want to do extra labs with us. They say, Doc, I already did labs with my primary care doctor. Can't I just do it with them? However, if I have a strong suspicion, I will also check some lab work to primarily really rule out thyroid disease and then also look for other skin conditions on examination as well that can be associated. But again, making the point that your alopecia areata did not cause these other conditions. I also like to note that if someone does have eczema along with alopecia areata, there is some evidence that shows that those patients tend to have a worse prognosis as well, just keeping that in mind. So certainly wanting to look out for that other concomitant diagnosis if they do have alopecia areata.
Yeah, and like you said, it's not that uncommon. If that immune system's flipped, it's not surprising then that maybe other places, it's kind of off balance and throwing the skin a little bit haywire and developing things like eczema. But the good news, as you know, I mean, we're in an era of treatments for eczema or atopic dermatitis that we've never seen before. Obviously clinical trials for oral therapy for vitiligo that we've never seen with one FDA-approved medication we've got topically. So it's an exciting time, to a degree, if you have alopecia areata, that we may have some options that could benefit you. And I think that's where people don't know, where do I even start with treatment? And some people even forget you go to the dermatologist for treatment for these types of things, because automatically they might even ask their salon, partner they work with, if they're with their beautician or whoever's working on their hair artist, and say, hey, what do I need to do for this? And not even recognize it's a medical condition. But I think you're probably as excited as I am to talk about treatment because of all the latest developments that we have now for alopecia areata.
I think that's extremely important. I remember years ago, we didn't have many treatments for alopecia areata. We had some topicals, some steroids, etc., and really have come into this arena now with so many therapeutic options and many more in the pipeline for our patients, which certainly makes it very exciting to treat this condition. To your point, I think it's very important to recognize, and that everyone recognizes, that alopecia areata is not a cosmetic condition. Fortunately, that thought has really gone out the door. However, it is still very important to stress that, because we know that alopecia areata, again, can be very emotionally distressing to a lot of patients, no matter what the age. Not just women, not just adolescents or teenagers or children, but also males, older patients. It really can be quite a distressing condition. And when these patients come in and we make an impact on their quality of life, I've had patients who come in tears. And once we treat them and we're able to regrow their hair, they are smiling. They want to hug you. They are so happy. And it really makes your job as a dermatologist so much more rewarding. One of my favorite aspects is being able to treat these patients and getting it out there that this is not a cosmetic condition. We are here to help you. There are things that we can do, and let's do it together and really improve your skin condition.
Powerful message from you, Eric. I really love that, because you're right. I think patients, are like, this definitely to them is not a cosmetic concern. And unfortunately, it takes us a while to convince our payers and sometimes the insurance companies that this is truly a medical condition that's deserving of time and attention. And just like anything else that we treat, because you can see the impact on a patient's quality of life. I mean, they don't want to go out and socialize. They don't go to work, school, kids get made fun of, they get bullied. Even for adults, it can really impact their productivity. And just what I talk about, being in that, game of life. If you have your best skin, you're able to be your best self in this world. So you're right. We have a great opportunity to impact people there. But treatment, as you know, has really come a long way. So I'm going to mention the S word, because I know a lot of my patients hate to hear this word, steroids, right? Like, kind of starting, back from kind of just where we've started with treatment, topical or intralesional steroids. So I was going to have you kind of go through sort of, the evolution of treatment, and even some of these treatments we still use today, obviously, and why, they can be effective, and, kind of highlight where we're at now, which I know is an exciting time.
Absolutely. So, early on, if someone has localized alopecia areata, just a few patches, really still one of my favorite go-tos are topical steroids for children. You can also use topical steroids for adults. In my experience, I find that topicals work better for children. And of course, adults can tolerate intralesional steroids. So essentially, we are injecting cortisone right under the skin where you have patches of hair loss on your scalp or eyebrows, for example. And what that does is it decreases the inflammation. Essentially, if you want to think about it very simply, it kills off those immune cells, sends them away. So the hair is then allowed to regrow. Because alopecia areata, is not a scarring alopecia. The hair can still regrow. Certainly, other types of hair loss where you have scarring, topicals are not going to do much. Once you get rid of the hair follicle because of scarring, you can no longer regrow a hair. But with alopecia areata, that hair follicle can still regrow if you get rid of that inflammation. So for localized disease, topicals, intralesional steroids. Now, one thing we used to use as well in conjunction with this, if somebody was progressing, was oral steroids, so prednisone. I remember treating patients with weeks and months of prednisone and trying to get them on a stable dose. But that required a lot of monitoring, regular bone scans because of the risk of osteopenia, osteoporosis, ocular exams to rule out cataracts and glaucoma, and then really keeping an eye on blood sugar and everything else that comes along with long-term steroid use. We also had methotrexate, also in addition to prednisone. That also required a lot of aggressive lab work monitoring, liver, kidney function tests, etc. And now we've really advanced further where now we have JAK inhibitors, oral and topical JAK inhibitors. In my experience, topical JAK inhibitors, not that effective. However, oral JAK inhibitors, we now have 3 of them FDA approved for severe alopecia areata. And one thing to know from a clinician perspective is that severe alopecia areata is defined as at least 50% loss of the scalp hair. Now, if somebody has eyebrow or eyelash involvement and they have less than 50%, I still call that severe. That's still a severe alopecia areata case. And in that case, those patients still qualify. And the 3 that are approved right now are ritlecitinib, baricitinib, and duruxolitinib. And those are certainly effective options for our patients. They're FDA approved and certainly can be used in a wide variety of our alopecia areata patients. Other things that have been used, of course, in the past, you have topicals such as squaric acid, which essentially creates almost like a contact dermatitis, poison ivy-like reaction to essentially cause inflammation and then decrease the inflammation that's causing the alopecia areata. Anthralin is another one topically. Light therapy has been used. But I would say that my go-tos now are intralesional steroids, topical steroids for localized disease, and now I go straight to the oral JAK inhibitors for patients with severe alopecia areata. And even one that's called tofacitinib, which is not FDA approved for alopecia areata, that's one of the first ones. I still have patients on that medication, and even though it's not FDA approved, their hair's regrown. They don't want to change. They don't want to switch medications. My hair's regrown. I don't want to risk going on something else that may be less effective.
Well, I'm going to break down a few things you mentioned there. So one, just when you mentioned, hey, I don't want to stop it, my hair's doing better. What kind of expectations do you set for treatment? And again, we can probably break this down, right? If you have more localized, like maybe individual patches versus more severe disease, how do you really explain, what the expectations are? Is this going to regrow permanently? Should you have cycling? Do I get to stop my medication? Because that's what a lot of people want to know, right? Can you give them something for a few months and boom, the hair's back and then you're done? I'll let you deliver the bad news, Eric, because we know what the truth is. Yeah.
Yeah. So, in essence, especially for more severe forms of alopecia areata, you're probably going to be on the treatment long-term. And I will say most patients, if they've lost all of their hair and they've regrown it, I don't really get much of that pushback saying, you know what, my hair regrew. I want to stop it now. Most patients say, there's a risk that I'm going to lose. And I tell them, yes, it is a very real risk that you will lose some of that progress. Now, the good news is if you do stop for a reason and you resume, in most cases, that hair tends to regrow again. But again, you're going to need that long-term follow-up because every patient's a little bit different. Can I say that every patient will lose their hair regrowth if they stop the JAK inhibitor, for example? I can't say that, but I would say as a general rule of thumb, if you stop the treatment, you will likely lose the progress that you've made. Now, for localized disease, I have patients that I will regrow them with intralesional steroids or topicals in younger patients. And many times that hair will stay regrown. However, if they develop a new patch, they know to call the office. You need to have this open door policy where if a patient calls saying, I have this new patch, or I think I have a new patch, a little bit thinner, this area on the back of my scalp, you bring them right in. And sometimes they're wrong. It's actually totally fine. Other times, you know what? They're having a recurrence of their disease, and you can inject them right away and then promote that regrowth. And that, of course, requires monthly visits until they fully regrow. And then once they fully regrow, I then space out those visits 2, 3, 4 months, eventually just as needed. And again, calling us back if it recurs. So it's very patient dependent. As I say to everybody, your body does what your body wants to do.
Mm-hmm.
You may regrow, you may not regrow off of treatment. But one thing that I know for sure is if you did well with the treatment, certainly continuing it is, in my opinion, the best option.
And I think there's a lot of truth to that. There is some unpredictable nature to all these inflammatory skin conditions we treat, whether it's psoriasis or alopecia areata. And, there are people that don't follow the playbook, right? And so you have people that do, well on therapy for a while, and then they lose again, and then they rebound back and they start to grow hair again. But I think it really highlights the chronicity, right? This is a chronic condition we treat, because in dermatology, I think a lot of people think what we do is so short term, that we're just treating people for a few months, they have a skin issue and boom, done. But we treat a tremendous amount of chronic disease in dermatology. And this is a great example where we're looking for things, yes, to improve what you have, but unfortunately, then there's probably going to be a maintenance plan that we got to put on board and to get you maintained for that period of time, because that typically, as we know with alopecia areata, you're going to have recurrence once we stop therapy, and people can have periods where things worsen. Maybe they do get stressed or something happens and kind of veers off course, but we can bring you back to a good baseline with some of the medications that we have today. And I think too, you highlight too how it's important, the oldies but goodies that may still have a role, especially in patients that may not be good candidates for our newer therapies. And sometimes we're mixing, things up too. We're doing more than one thing to achieve optimal results for patients as well. But it's so exciting to know where we're at. And then the emotional part of the treatment part, we've hinted around this throughout our conversation today. I wonder if you had a patient example that you could share with us in our last couple minutes about just the impact, the suffering they went through having alopecia areata, the opportunity you had to treat them, and how it really changed their life.
I can give a few examples, but I'll kind of group them into a group of kiddos, for example, adolescents. So I volunteer for Camp Discovery for almost 20 years now. And of course, 20 years ago, we didn't have these medications for alopecia areata. Not, of course, for children, not even for adults. I've seen children who come to camp, have no hair whatsoever. They're embarrassed, they're shy. And then coming back, a year or two later, their hair is regrown, and just seeing the impact. They were sad, emotionally distressed, and now they're totally different, right? That confidence that they have, especially going to their, teenage years, where certainly bullying is such a big issue for kids without alopecia. You had alopecia areata, unfortunately, some of these kids, people who are not aware of this condition, especially when they have alopecia totalis, losing all of their scalp hair, they think that they're sick, that they have cancer, for example. And now they've regrown their hair, and this newfound confidence that we just see in these children, these adolescents, is certainly tremendously impactful. And I also see this in my adult patients who certainly are professionals, who now they want to work from home. They don't want to go to work because they've lost their hair, whether it be the scalp, the eyebrows, and the eyelashes. And I've seen this. I can think of a couple of my female patients where they certainly had this impact, and they want to start working from home, wearing a wig so nobody could tell that they had, quote unquote, fake hair. They had a wig, right? We put them on these medications, going back to work, regaining that confidence. Because let's be honest, when these patients do not have that emotional stability because they've lost their hair and they're emotionally distressed, it certainly has an impact on their quality of work, their quality of life, and impacts them all around. And certainly, again, one of my favorite parts is just seeing the change in these patients when they come back to our clinic and they're totally different, where they're happy, they're hugging. They can't say enough. They say, we're a godsend. And I said, listen, we just know which medications to give you, how to treat your skin disease. And I tell them, don't give me too much credit, because 15, 16 years ago, there wasn't too much I could have given you without affecting your bones and your eyes and everything else.
Yeah, what an impact we can have on people, with our medications. And, if you're out there and you think you have alopecia areata, somebody that does, go see, your dermatologist. Dermatology is here to help with this. We have great tools at our disposal. It's not something you just have to put up with. We can really make a difference for you. Eric, I want to thank you so much for coming on the podcast today. It was great to hear your perspectives on alopecia areata.
Thanks so much for having me, Shannon.
Of course. And stay tuned for the next episode of Derm-It. Don't swear about skincare.
Thanks for listening to Derm-It Trotter. For more about skincare, visit dermittrotter.com. Don't forget to subscribe, leave a review, and share this podcast with anyone who needs a little skincare sanity. Until next time, stay skin smart.